Hello everyone, I'm Luis Ortega from PCR Online and Every Intervention Journal, and today we have the privilege to interview Professor Marco Valgimigli for the Cardiocentro Ticino in Lugano, Switzerland. He's the PI of the MASTER-DAPT trial, which was presented in the ESC meeting of 2021 as a late-breaking clinical trial. Professor Valgimigli, it's a privilege to have you here in PCR Online.
Thank you, Dr. Ortega. It's a privilege to be interviewed by you.
We will begin with a little bit of Q&A, but the first question is if you can make a short warm-up of the main result of the trial.
Sure. So we set up, and when I say we, I also would like to extend the notion that Peter Smits was actually co-PIing the study together with me, and we had the privilege to lead this study together with a very broad team of very expert investigators, being part of the executive and steering committee membership. So in this study, we designed the study to answer a very critical question: how short can we go with the APT in a selected group of patients that are going PCI and being at high bleeding risk? For that purpose, we randomized patients at 30 days once they were free from ischemic events and in whom no subsequent revascularization was planned. These patients were randomized to immediately stop the APT at 30 days and continue with a single antiplatelet therapy, or continue the treatment for at least 2 or 5 months in patients with or without indication to OAC respectively, and afterwards continue with single antiplatelet therapy, which in this study was either aspirin or P2Y12 inhibitor. We set up 3 primary endpoints which were ranked, meaning we had to follow a precise order. First, the NACE, the net adverse clinical events, which was a composite of death, MI, stroke, and major bleeding. And we wanted to test the non-inferiority of abbreviated EPT compared to standard EPT. If that was met, we could go forward and test the non-inferiority with respect to MACE, death, MI, stroke. And if non-inferiority for both endpoints was established, we were finally allowed to test the third endpoint on superiority basis, which was major or clinically relevant non-major bleeding. To wrap up the study results, we met all 3 primary endpoints. So the study really provided a very definite and clear answer that if we shorten the APT duration down to 1 month as compared to a more prolonged APT regimen, that is associated with no increase of ischemic events, preserves net adverse events, of course, and actually is associated with a reduction in major clinically relevant non-major bleeding.
Many thanks for the summary, Professor. And my first question when we enter this Q&A is about the patient selection. So you used different criteria. Which was the most relevant criteria you used? I know you used the precise-DAPT, but I see there were also another selection criteria regarding the high bleeding risk definition. So can you summarize about this?
Absolutely, it's a very good point. When we designed the study, the HBR criteria for defining HBR patients were not actually developed yet. We were probably not even starting working on that topic, but I think we have been contemporary already in a way, because we did not want to restrict inclusion to a specific HBR population. And therefore, we had a mixture of both single clinical criteria, such as age, such as prior bleeding, and so on and forth, together with a score which had been previously validated, including precise-DAPT. If and when we look at the distribution of patients in our study, first point to be said is that we had a mean of 2.5 HBR criteria per patient in both study groups, meaning that on average, our patient had 2 criteria fulfilled at the same time, and even slightly more than this. So this was a truly high bleeding risk population, and this is reflected by the very high bleeding rates, which was at the end of the study even higher than it was previously anticipated when the study was designed. If you look at distribution, age equal or greater than 75 is apparently the main driver for inclusion, but in fact, in only 17% of patients, only age led to inclusion. Then we have OAC, the need for oral anticoagulation, that was also prevalent, 36%. But again, if you look at the number of patients entering the study because of oral anticoagulation, that was only 11%. So the message I would like to bring is that we had a fairly I would say balanced distribution of all criteria in the study, and only few of them got into the study because of age or oral anticoagulation. In fact, it was in the majority of patients a combination of many.
I don't know if you agree, but in my mind, I could say this is an all-comers, high bleeding risk population because you treat almost everyone and you can include almost everyone in the trial.
That is correct. That was our aim. It's difficult to answer whether that was really truly a consecutive HBR patient, because of course, once a patient needs to get into the study, you have to have a lot of procedures in place. You have to speak to the patient, explain the study purposes. The patient has to agree. The patient has not to think about it being part of the study in a setting in which the patient had almost 30 days to think whether he wanted or she wanted to participate, yes or no. So it's impossible to tell, yes, it was a truly all-comers, but we did all we could to get there.
Okay, and that's what another point I was asked. There was a 30 months running phase in which patients should be on eventful and should be without bleedings, if am I correct?
This is not entirely correct, Luis. So we didn't want to have patients with a recurrent ischemic event. That was something we didn't want to have, for the reason that, of course, if a patient has a recurrent MI 14 days after stent implantation, we did not think that were an equipoise in randomizing patient to stop DAPT immediately afterwards. But if the patient had a bleeding event from PCI and before randomization, and that bleeding event was in a way over, the patient basically could resume DAPT, that patient was actually eligible. So we excluded patient with any recurrent ischemic events and only patient with active bleeding at the time of randomization. And active means for us a bleeding according to which the DAPT had to be stopped and at the time of randomization could not be reinstituted. That was basically the population we wanted to have.
Many thanks for the clarification. This is an important point because it makes more broad the inclusion criteria, and I like it. And you already talked a little bit about the three co-primary endpoints. This is not something usual, have a major trial with three primary endpoints. But I will specifically want to ask you why you select that order. If you can provide the rationale or why you, because other trials have put bleeding first as the first hierarchical endpoint, which is you can say the easy way. But I want to have your rationale and your explanation of why you select this order.
Yes, I think it's a good point. I honestly, personally don't think there is anything right or wrong here. It's a matter of personal taste. When you are comparing a more prolonged DAPT duration with a shortened DAPT duration, I think the easiest goal is to show a difference in bleeding. That's why we did not want to start with bleeding to claim that the study was positive. At the end of the day, in our mind, the study had to be positive only if ischemic events did not differ. And at that moment, the shortened DAPT would be associated with a lower bleeding risk. Therefore, we said we are going to test the easiest endpoint at the end. If the MACE is not going to be met on a non-inferiority basis, well, at the end of the day, I could not care less if I am also reducing bleeding. And that's why we follow that order. We thought it was the most logical and fair approach to use that order. By saying this, I don't want to state anything against testing bleeding first. I think it is perhaps making the study a little bit more sound. That's what we thought when we designed the study.
I think it reinforced the hypothesis, and it's the most appealing and compelling way to do it. But it has a statistical penalty, which derived from more than 4,000 randomized clinical trials. Congratulations for that. It's not an easy task. And then I want to move on from something that I believe could provide a little bit of discussion, which is the selection of only one DES platform in the trial. So in this case, it was the Ultimaster or Ultimaster Tansei. So can you explain us your perspective about if it is an asset from the trial or is a weakness? What do you believe about this?
Well, of course, I think here also there is not right and wrong. I think there are a lot of values in selecting one single stent platform. First, from a trial standpoint, we had to choose a stent in whom 1 month EPT was on label. Because otherwise that would carry a lot of implication with respect to running a study. And that's why we selected the Ultimaster stent, because Ultimaster stent had already, when the study was designed, a 1 month CE mark. So that CE mark comes from the fact that first, Ultimaster was based on prior mechanistic study where actually 1 month DPT was already tested. The primary point of the study was in fact OCT findings. That study was called Discovery 123, where they were looking to the STRAT coverage at 1 month versus 3 months. And that stent already showed that at 1 month, the vast majority of stent rats were already covered. And also by looking into patients in whom DPT had to be discontinued in prior Ultimaster studies, and actually nothing happened in this patient. And Ultimaster, when the study was designed, was one of the few stents with such a CE mark. Secondly, I think we did a very clean study that is completely answering the question for that specific stent. Now, of course, the limitation of the exercise that you do not know, and I do not know either, whether the results are applicable to other stent platforms. That is the limitation, but at least we have a clear answer. If there is a minor difference between stents, even newer generation DES, of course, that could be reflected in noise into a study, and that would result in the impossibility to give a clear answer to any of the DES employed. At least we have a clear answer to one of the DES, which is the one we actually, that has been used in 99.8% of the patient in the study.
I agree.
And today I was actually a bit skipping away when I was presenting the study during the Q&A session from that specific answer. And my comment was, look, in trying to answering that point, I'm transitioning from evidence, the MASTER-DAPT study result, into opinions. Of course, you may have one opinion, I may have one other opinion. Would be nice actually to share with you some numbers to back up any kind of opinion. We had more than 6,500 Ultimaster stents implanted in this study because there was an average 1.7 stent per patient. And we had overall 0.2% non-Ultimaster stent implanted in the study, which basically means less than 20. We had overall in the study 18 definite stent thrombosis. When we look into the numbers, 2 of these 18 stent thrombosis occurred in non-Ultimaster stent. So if you make the numerator plus the denominator, you have 2 divided by less than 20. On the other hand, you have 16 divided by 6,500. Of course, that could be a biased comparison, and it's not a randomized comparison by definition, but this is not leaving me entire reassurance that if you would use a different stent platform, you will have completely equal results. So I think each stent type, even newer generation, when you go really very short with DPT, may have a different stent profile with respect to safety.
In neurointervention, it was published recently, the Twilight stent study, more or less the same results in all the platforms. But I really like the concept that this was a drug study, not a device study. Because, you know, in the back years, we have a lot of, not a lot, but some HRV trials, but they were device trials, not drug trials. And I want to move forward, Professor, and I want to enter a discussion about in the co-primary endpoints. The MACE, there was a lot of discussion on, I believe, in the Congress and also in social media about and also the editorial in New England. There was a paragraph making analysis of it about the non-inferiority margin for the ischemic events. If you can provide your insight, your opinions, and some data of what was showing the MASTER-DAPT trial regarding this aspect.
So thank you for this point, which is of course very controversial. When you are planning, designing, and interpreting a non-inferiority study, you have to accept the fact that you will still have some degree of uncertainty. Non-inferiority does not mean equivalence, does not mean identity. So you need to accept some basically difference between the two potential strategies that are being tested, or I would say uncertainty more than difference. When we planned the study, we anticipated a specific event rate for both NACE and MACE, and then we choose the non-inferiority margins that would preserve at least 30% of that event rate. That is the rationale for having the famous 3.6 and 2.5 for NACE and MACE respectively as non-inferiority margins. The truth is that the event rate for both NACE and MACE was lower than what was anticipated. Now, if we calculate post hoc the 30% of the actual event rate for both NACE and MACE, we would still meet non-inferiority. So by acknowledging the fact that our original sample size assumption was based on wrong expectation of event rate, we should also acknowledge that with actual event rate in front of us, we would still meet non-inferiority by having a 30% non-inferiority margin. Now, if we transition from the complex statistical scenario that we have been discussing into, let's look very pragmatically into the numbers, I think even the person who is not very familiar with statistics would probably accept that there was no clear signal that shortening the EPT down to 1 month was associated to extra ischemic risk. Let me go into the numbers. There were 2 secondary endpoints which were numerically, not significantly, but numerically disfavoring 1 month of DPT. They were stent thrombosis, and we had 7 stent thrombosis with standard DPT versus 11. So overall, there is an absolute difference of 4 out of almost 5,000 patients. For me, that is a peanut. And the other one, which is probably more relevant, is MI. We had 60 myocardial infarction in the 1 month DPT and 49 in the prolonged DPT. So if you want to overemphasize the number, that again did not reach any statistical significance, but still was still a 30% relative increase. And absolute difference was 11 extra events with short DAPT. On the other hand, if you look at the stroke rate, there were 23 stroke rates in the prolonged DAPT and 11 less stroke events in 1 month DPT. So basically the excess of MI, an excess of 11 MI in one arm, was completely compensated by an excess of stroke of 11 again on absolute terms in the prolonged DPT group. So if anything, I think the risks were completely balancing out between MI and cerebral events. And allow me to state that I would much prefer myself to have an MI than a stroke. We have seen that many times. A stroke has a much more important prognostic implication with respect to both mortality and morbidity. So I think the study is entirely reassuring. If anything, if you look at just the number of deaths or CV deaths, they were numerically lower with abbreviated DPT. So nothing is perfect when you are planning a non-inferiority study. Of course, the non-inferiority margins are always too wide at what you would like them to be. But at the end of the day, I think there is really no signal here that 1 month DPT should not be the way to go forward.
I also will mention that it's all about feasibility of trials. You know, we will like how to have superiority trials of everything, but they are not feasible, and sometimes because they're too large sample size. I also will say that I believe it's important talking about strokes in this type of trials, because some of these trials, it's not the case only of MASTER-DAPT, take aspirin out of the equation. So, and we know that aspirin may prevent stroke and TIA. So moving forward, I want to ask about something at least I think may quite cap the attention from the readers, is that you use a per protocol analysis for some of the endpoint instead of an intention to treat analysis. So what's the rationale for having this type of analysis in the trial?
This is a very controversial topic, and again, here there is not something which is completely right or completely wrong. Normally, you should basically be able to show non-inferiority both at ITT and per protocol analysis. That is the rule. But by definition, you have to specify which one is the primary analysis. We thought to use the per protocol population. To be very clear, we did not do a per protocol analysis. We simply ran the non-inferiority test in the per protocol population because we wanted to have a population of HBR patients who did not fulfill any exclusion criteria and who had implemented the allocated regimen. That was the rationale. So if you're running a study where you're comparing 1 month DPT versus whatever, 6 months DPT or any prolonged treatment duration, and then in the 1 month DPT, patients who are supposed to stop DPT do not stop this treatment, of course, it will be very easy to show non-inferiority because you don't have any difference between the two study groups. So we said, if we want really to do it right, let's try to show non-inferiority in patients who stick to the protocol mandated regimen, meaning 1 month versus a more prolonged DPT duration. And that was the rationale for the per protocol. However, I think here it's not an issue at all because the results of per protocol and ITT are completely identical in MASTER-DAPT. So there were not so many patients deviating from the per protocol. And in fact, the two analyses are conveying the same messages. We met non-inferiority for both.
I always was quite interesting for me that the adherence was very high in both arms of the trial. In the supplemented appendixes, the graph from the adherence, I was totally amazed that it was like over 95 or 99. But there was, you know, a decrease in the end of the trial, which is, you know, as you are an expert on that topic, is quite common on this type of settings. And we have a very interesting discussion. I want to make only one more question. It's about future. I always want to ask about futures. I would like to know if you are planning a very complete, dedicated analysis about how oral anticoagulation may interact between the arms. And also, I would like to know what is preparing Professor Valgimigli for the future of studies about HRB. This is a hot topic right now, and what you believe is in the horizon of this type of patient.
So in fact, the OAC sub-analysis is being presented at ESC as we speak tomorrow, which is going to be the 29th of August, and it's going to be published simultaneously in circulation. So wait a few hours and you will know a lot about this topic. I would not anticipate anything, if anything, because if you post the interview before tomorrow, then I would spoil the presentation.
I have to say PCR Online always respect the embargo. We are very good doing that.
Okay, then, but let Peter Smith, the co-PI of the study, present the data and comment upon the data. But that's, of course, it's a very interesting analysis because you're right. The OAC population, the non-OAC population are two studies nested in one. So it will be very interesting to look into the data with that respect. What is getting into the horizon? I think for the HBR, the topic is quite clear. If you still want to further investigate the topic, I think you would need to ask an additional question. Can you really get rid of one antiplatelet agent very shortly after the PCI, as long as you have a decent P2Y12 inhibitor on board? And decent, I'm not discriminating the type of P2Y12 inhibitor. I think all three available are extremely good. I'm only worried about the fact that we know that 5 to 10% of patients do not respond to clopidogrel. That is my only concern. If you could run a study with a relatively low dose of prasugrel or low dose of ticagrelor, I think you could do that. But that, of course, needs to be proven. If you look at the OAC studies, the OAC studies continue aspirin already a few days after PCI. And when you pull these four studies together, you do have a signal with respect to higher stent thrombosis risk. That needs to be interpreted in the context of clopidogrel monotherapy together with the oral anticoagulation. So I suspect that increase of stent thrombosis is coming from the fact that in some patients, there is actually no antiplatelet therapy on board, only oral anticoagulation. So I would love to see a study where you perhaps use low dose of prasugrel or low dose of ticagrelor in association with OAC immediately after PCI without aspirin, and probably that may be associated with no increase in stent thrombosis and a lot of gain with respect to bleeding risk. The next question that needs to be discussed is in which patient you now need to prolong DPT. So we have been investigating HBR quite a bit. Probably now it's time to answer the opposite question. In which patient you should not stop DPT and actually prolong DPT as much as possible, and whether in that specific high risk subset of patients, whether again a P2Y12 inhibitor monotherapy would probably do the job. I think these are the two most critical questions that need to be answered in the future.
That was very interesting, and it of course gives a lot of ideas for all the investigators and all the people looking at this interview. I am delighted for the interview. Many thanks for your time, Professor Valgimigli. I know you are a busy man and you have taken so much of time for PCR Online. We are very glad to have you here. I want to congratulate you, Professor Smith, also and all the group of investigators of the MASTER-DAPT, because it's not only my opinion, but also the opinion from other people in social media. You have set a new standard of care for this type of patients. So it's something quite an achievement, I have to say. So For all the viewers in PCR Online, I want to say goodbye for myself and please stay tuned for all the interviews we are doing in the ESC 2001 meeting covering the trials that are related to interventional cardiology. So stay tuned with us. We are making the best we can to keep you informed of all the trials we are presented in the ESC meeting. So thank you, Professor. If you want to say goodbye to the people, we'll also be happy.
Thank you very much for having me.
Thank you. Good night.